I'm going to ask Mike, if I may be a little provocative.
Which Mike?
Sorry, no, Mike Zalewski, but you can all pitch in. So Mike, you made a very interesting comment in the previous discussion about rectal cancer being given a suboptimal dose of radiation, which is why it needs to be followed by surgery. Is it a completely crazy hypothesis to suggest that you could do the same with prostate, where you give a lesser dose of radiation followed by surgery? So, in other words, neoadjuvant radiation followed by surgery, which could have a superior outcome. Is it completely crazy, or is it something that could be looked at? And then I have a second question. Sorry.
No, I don't think it's completely crazy. Especially you asked the question.
You don't have to do the surgery.
Maybe I'll butt in, but we've done this, and we published it. We gave 25 and 5, operated a week later after the last cycle, and there was significant incontinence problems.
Significant
incontinence
problems. But if we look at
that's actually I mean, I know Harry has a great deal of experience with, of course, in bladder cancer from years past, the era of preoperative radiation, and I would imagine that carefully delivered 5 Gray times 5. I don't know what the era was in terms of the radiation was given, because toxicity wouldn't be expected.
Rob
late
Bristow
90s.
and I did it, yeah.
It's interesting. So getting back to your question, I mean, yes, it's been done. I guess toxicity, obviously, as Neil said, could be a concern. When we use it in the postoperative setting, that's what we do very frequently, because theoretically of this hypoxic state, post-op, you need higher doses. Clearly, when we give salvage radiation, 60 to 70 Gray is adequate. And if we gave it in the neoadjuvant setting, a preoperative setting, we wouldn't give 5 Gray times 5. That is basically hypofractionation. We would consider a more protracted, lower dose per fraction, which would be 50 Gray. Would that result in incredible improvement in outcomes? I tend to doubt it, but
you've demonstrated such beautiful improvement in reduction of toxicity with the new technology and imaging and protection of the rectum, and also sensitizers as well to radiation. But the combination of all this, instead of saying, we've done it and it doesn't work, re-examine perhaps in the light of all these new technologies. So that was just a suggestion. The second one, sorry, and then I'll shut up, is none of you mentioned the possibility of an abscopal effect following treatment of the primary, whether it's by radiation or by surgery. Do you have any thoughts about it, or is it also something completely crazy? Any of you?
I think radiation alone in creating that abscopal effect, it's not that clear. But if, in the setting of immunotherapy, radiation could be a very valuable adjunct, and that abscopal effect has been, clearly demonstrated for other diseases. Whether we would actually see it in the setting of radiation, when we have trials, immunotherapy trials, clearly, needs to be studied. I don't know. Susan has some data.
We never saw it in any of the IPI trials per se. We did a combination of radiation, and it was very clear that when we did the radiation, nothing else changed. None of the other lesions disappeared. There was no evidence of pseudoprogression. Didn't seem to work. Melanoma, yes. Prostate, unfortunately,
The idea of the abscopal effect, though, is now being re-pursued in the modern era, so to speak. So there's a number of studies now giving radium either before, during, or after immunotherapy, either PD-L1 or PD-1 directed therapy. Whether those will be successful, they're all in phase 1 right now. But Susan was a PI of that study with the directed RT at a metastatic site in IPI, and it didn't work.
One of the things, though, I would say maybe the opposite of the abscopal effect, which is the concept of accelerated repopulation. And, with some of these oligorecurrences, when you surgically remove them, I mean, it's interesting. You have a patient with smoldering PSA for 5, 6, 7 years. You operate on him with a PSA of 5. The PET scan will show you all the lesions in theory. You remove the lymph nodes, and his post-op PSA is 5. Like, how does that happen? And it's hard for me to understand it, except this concept of accelerated repopulation, which is somehow the cancer wants to be at a PSA of 5, and it's going to grow faster to get back there for whatever unknown reason it is.
Ian?
I have a marvelous opportunity to query a multidisciplinary group of experts here. So I struggle mightily with management of nodes, and I'm looking here to Harry to my left to accomplish the randomized trial of node dissection for bladder cancer, and we're trying to emulate that, having finished accrual to the intergroup trial for bladder cancer. And we'll see. I mean, the thing that was sobering to us, Dan, as we were looking at developing the background material for that trial, was the experience in other organ sites. And we in urology oftentimes don't pay attention to smart people like Phil and others who tell us that you can learn from other organ sites. And, gastric and esophagus and pancreatic, relatively unresponsive to extensive node dissections. And so we have 3 kind of groups of individuals sitting down here up front, and wonder if you could arm wrestle each other. If you have disease, why surgery versus SBRT versus systemic? Because most of these patients are failing systemically. How would you approach this in the patient who has clearly higher risk disease? Any thoughts in the group as to other possible, because we know the GU Steering Committee looked at some of these trials of SBRT for oligomets. Why are we not doing this instead of the relatively archaic go after it surgically when you can map the PSMA scan to radiotherapy, or why not just treat it systemically? I'm interested in your thoughts. For Harry's.
Before you answer that, just to the surgeons in the audience, there's robust data now from other solid tumors that removing positive nodes in the regional setting, and certainly extended lymph node dissections in patients that may have node-tropic diseases of no benefit. And we also know that removing negative nodes has no benefit. So why is prostate cancer different than colon and breast and gastric and all of the others? And to Mike Morris, with these exquisite scans now that we see picking up this subclinical metastatic disease, are these METs biologically relevant, and do they deserve treatment? So to just answer Ian's question, so I think that the premise of the arm wrestling is that there's a binary choice here. I don't think that we really know what blend of multidisciplinary skills need to be applied to these. Systemic therapy alone just doesn't have a history of curing patients. So if you really do have micrometastatic, or now with these imaging techniques, metastatic disease or oligometastatic disease, I think that either they're not going to be curable with systemic disease with systemic therapy alone, or if they're going to be curable, it's going to take more than just some form of systemic treatment, unless you define cure as prolonging death by something else, by something else. And then, Harry, I think that your question is absolutely right. That is, what we're detecting, we don't know what the relevance of those lesions are that were at the point of imaging, weren't evident. Are those driving death, or will they drive death or disability? I don't think that we have the answer yet, and I wish I could say that it's being systemically studied, but the way that these imaging agents are now rolling out, as long as you fly to the right place, you can get it, and what happens to you after that is up to your local guy. There's no systematic assessment of what what happens to those lesions.
As a follow-up to that, Mike, your work with the FDHT, showing that the androgen axis is active, being a good prognostic factor. Have they, and you probably doing this here, is that correlated with the transcriptome in those metastatic sites? Have you done biopsies to look at the AR transcriptome pathway of those solid tumors? Is it correlating, or not? I'm sure stand-up cancer or something you might have done.
Most of those lesions were imaged in an era before we had impact, and most of those are bone, and so unfortunately we can't go back really and run those. But for those that we do have soft tissue disease, we are now going back and pulling those out of pathology and then running impact analyses on those so that we can see. The other question is what is really accounting for those? Is that really a genetic issue, or is that a splice variant issue?
Oh, yeah.
Right, because ARV7 and the other splice variants don't have a ligand binding domain, so that could just be, a post genetic issue.
Sure. That certainly would get to Harry's question if you did something.
But Harry, I wonder are we overthinking this too much? I mean, this patient that has metastatic disease, we just found it earlier. I mean, if they are biologically, I don't think there's any suggestion it's going to be indolent disease forever, if that's what you're asking.
No, but there's a population, at least in other tumor sites, in which patients have nodotropic or regional disease only. It does not portend metastatic disease. Taking those nodes out has no benefit in overall survival. It may improve and, in fact, impact local regional or local recurrence. But overall survival has limited impact. I'm not going to extrapolate to prostate cancer. I think these diseases are unique. But the robust data to show that is a metastatic deposit and it has to be removed. And if we don't remove it, it portends an adverse outcome that's not already predestined is unknown.
If you put all of those patients that were treated anecdotally in a trial, we would have our answer. Right?
Yeah.
Randomize the first patient when you have a question. Go ahead, a question right here.
Yes, I was wondering if you found any new promising markers that might be good candidates for companion diagnostics.
In what
For
countries?
other than androgen targets, something that you might find useful for a companion diagnostic approach. Yes.
To a specific therapy, did you have in mind, or?
Yes, I mean, have you come across anything that, we know, like, say, with the BRCA2 or the androgen targets, do you see anything else that analogous that might come up for companion diagnostics?
Well, I think for everything that we just talked about, there's a companion diagnostic. For immuno-oncology, there are assays to detect for the target to determine whether even detection is relevant. For the PSMA-directed therapies, many companion diagnostics, imaging, serology, tissue, to see whether PSMA expression has relevance in terms of rates of relapse and site of relapse. For AR-directed therapies, there are companion diagnostics being developed as well. I don't know, do you have any comment on that, since you are in that business, so to speak? Yeah.
Other comments?
But I'd say that the companion diagnostic for the surgeon is the PET scan.
Could be.
Yeah.
Yeah. Could be an image as the biomarker, not necessarily an assay or something.
Right.
Last question, final question?
Yeah, I have one question. I just want to make a quick point to Mike's point, which is, I think, at least, I'm not sure how is here, he could correct me, but as far as I'm aware, all the cases of high ARV7 are always associated with high full-length AR at the same time. Mm-hmm. So I would be surprised if it were just ARV7. Sure. But I guess another question, especially when we're talking about imaging and node dissection, is would you consider salvage node dissection in the case where all imaging are negative, where somebody is also a candidate for salvage radiotherapy? And
You mean as an alternative to radiotherapy, to a node, you mean?
Especially if they had suboptimal node dissection initially.
So, I think if you choose to treat a nodal recurrence with radiation or surgery, I think the surgeons are more surgically inclined, and we think we could probably do as good or a better job surgically, and I think the radiotherapists probably feel it would be the same in their own domain. I don't know what kind of doses with SBRT you can get in now. Mike?
I personally feel that you'd do a better job with either a visible or a PET positive node than we can do, because we have bowel in our way, which will preclude us from giving tumoricidal doses. So, but I think your point is well taken. We see, perhaps from community settings, some urologists who don't do node dissections or do node pluckings on patients. The patient has a negative, patient has a positive margin with actually Gleason 8 disease. They come to us for radiotherapy, and the real question is, do we treat the primary site and the nodes, the nodal area as well, in a bed that's never been really appropriately dissected? And we're exposing the patient to more bowel-related toxicity. I think such patients, if there was at least some kind of an indicator from imaging that there was something there, maybe that would be the ideal scenario. Of course, if it's microscopic disease, we could get away with 50 gray. If it's gross nodal disease, I think a node dissection may be better.
Great. You have a question, Vin?
Yeah, I just want to make a quick comment about that. You know, our experience with salvage node dissection has not been quite as robust as yours. We have only 2 patients out of 48 that have a complete biochemical recurrence-free rate at 3 years. Sorry, got this laryngitis I can't get rid of. The issue that we have with redissection of patients that have had previous dissections, even if it's a limited dissection, is that the anatomy is disrupted. There's a lot of scar tissue there, and it becomes very difficult to do more than a extended node plucking, and especially if you don't have visible lesions. Because to go back and try to do a full pelvic lymph node dissection in somebody that's already had a dissection before or had radiation on top of that is really very difficult.
Just to clarify, are you talking robotic or open or either?
I don't think it makes a difference.
Okay.
And
Yeah.
you know, I hope we've answered that question here. You know, we've looked at our open experience and our robotic, specifically in terms of nodal yield.
In the salvage setting?
And not in the salvage setting.
Yeah, that's what I'm
not in
talking.
the
We're talking about a salvage
right.
setting. So.
But I don't see where it would make a difference,
Okay.
quite honestly, having operated both ways for many years. Yeah. So I think the real role for salvage node dissection is in those patients that have not had an upfront node dissection. And I think where we should focus our attention is reducing the number of unnecessary upfront node dissections we do, perhaps with PSMA scanning of all patients ahead of time, and then using the salvage for those few patients that didn't get a dissection but then recur later. That's really where I think the role for salvage node dissection is. And hopefully at that point in time, we'll also have intraoperative PSMA detectors that we can utilize.
Interestingly, though, at least, I don't know, in my backyard, everyone has different backyards, but I don't see many obturator recurrences. They tend to be external iliac or presacral.
Perirectal.
I don't see them obturator.
So just to Vin's point, for someone that says, well, why don't you do the clinical trial that Vin just described? It'll take 50,000 patients to actually show a benefit in the setting of stratifying patients by PSMA negative, randomizing them to a node dissection or no node dissection, doing a salvage node dissection on those who didn't get the upfront node dissection to see if they benefit. So it's an undoable trial. So we have.
Not to mention the ones who you could probably cure, the ones with the microscopic disease that probably would be PET negative.
PET negative.
And your best chance to do it is the first time you're there. I think we'd all agree with that.
Great. Well, thanks for the panel. 15 minutes, right?